Hello, dear students. So we're gonna start reviewing chapter 52, especially peritonitis. Um, this belongs to week 8 in the syllabus, right? We have reviewed 51, chapter 51 in class, so we are trying to catch up with these videos. Right now, let me start with chapter 52. The primary concepts that we're going to review are infection, inflammation, nutrition, elimination, pain, fluid and electrolytes balance. So, continued digestion of food and absorption of nutrients occurs primarily in the small intestine to meet the body needs for energy. Water is reabsorbed in the large intestine to help maintain a fluid balance and promote the passage of waste products. When the intestinal tract and its nearby structure become acutely inflamed, pain and infection can occur. Appendicitis, gastroenteritis, and peritonitis are the most common acute inflammatory bowel disorders. Ulcerative colitis and Crohn's disease are the two most common chronic IBD that affect adults. So let's watch the video of peritonitis to understand a little bit better. In this video, I think this video is the one that doesn't have any sound, but we are going to see the abdominal cavity. You see the liver there, the stomach. So basically they are starting to remove the organs, so you get a clear idea of what is in there. The jejunum, the small intestine, the large colon, right? They're putting back the intestine, and the peritoneum is that sac that is covering all the organs with the great omentum. Okay, so what's happening is that in peritonitis, in this example, they are taking an stomach ulcer as the reason for peritonitis. So the ulcer is going to release all these stomach acids and bile, and this product is going to leak into the abdomen. So you see, easily spreading in the abdominal cavity. Now think about all the material that is not being metabolized, right, because of this acute peritonitis. This is going to cause intense inflammation of the peritoneum, yes, and also is going to start forming adhesions and inflammation, right? Exudate. There you go. There you go. Okay, so this is a life-threatening condition that we need to avoid. Let's go back to the book. So peritonitis is a life-threatening condition, acute inflammation and infection of the visceral parietal peritoneum and endothelial lining of the abdominal cavity. When the peritoneal cavity is contaminated by bacteria, which is the case, that's why there is a lot of exudate and adhesions, the body begins an inflammatory reaction, walling off a localized area to fight the infection. If the process of walling off fails, the inflammation spreads and contamination becomes massive, resulting in diffuse, widespread infection. Bacteria gain entry into the peritoneum by perforation from appendicitis, diverticulitis, Pepsi ulcer disease, and from an external penetrating wound, a gangrenous gallbladder or bowel segment, bowel obstruction, or ascending infection through the genital tract. These are all reasons that can cause peritonitis. Okay, fluid is shifted from the extracellular fluid compartment into the peritoneal cavity, connective tissues, and GI tract this third spacing. The shift of fluid can result in a significant decrease in circulatory volume and hypovolemic shock. Severely decreased circulatory volume can result in insufficient perfusion of the kidneys, leading to acute kidney injury with impaired fluid and electrolyte balance. Peristalsis slows or stops in response to severe peritoneal inflammation and infection, of course. The toxins or bacteria responsible for the peritonitis can also enter the bloodstream from the peritoneal area and lead to bacteremia or septicemia. Respiratory problems can occur sorry, uh, as a result of increased abdominal pressure against the diaphragm from intestinal distension and fluid shift to the peritoneal cavity. Also, pain can interfere with respiration at a time when the patient has an increased oxygen demand because of the infectious process. The etiology. Common bacteria responsible for peritonitis include Escherichia, Streptococcus, Staphylococcus, Pneumococcus. It's not only related to the respiratory system, Pneumococcus, and Gonococcus. So the incidence peritonitis is the abdominal is the dominant cause of death from surgical infection with a mortality rate of up to 20%. It occurs most commonly in young adults who have appendicitis and older adults with those with whose immunity is often decreased. So we are going to see what is the assessment, the most important part of the assessment. In history, you have to determine the character of the pain, if it's sharp, cramping, aching, location of the pain, and whether the pain is localized or generalized. You're going to ask about the history of a low-grade fever and recent spikes in temperature. This is common sense. In all infections, we need to assess for pain and fever, or any spikes or changes in temperature. Common sense. Physical assessment, signs and symptoms. Depending on the stage of the disease, the ability of the body to localize the process by walling off the infection and whether the inflammation has progressed to generalized peritonitis is how you're going to conduct your physical assessment. The patient most often appears acute ill, lying still, possible with the knees flexed, and that's the guarding position, right? When they are protected and they don't want anybody to touch the abdominal area. And there is a lot of pain, facial grimacing with coughing and movement of any type. So the key features here, I have highlighted the ones that I want you to remember that are very important. It's going to be rigid bird-like abdomen, distended abdomen. Of course, if there is infection, there is nausea, diminishing bowel sounds, rebound tenderness in the abdomen. We spoke about that last time. Is when you press an area, and in the moment you are pressing, the pain is not present, but when you remove the hand from the abdominal area is when the pain appears. That is called rebound tenderness. Also, I want you to pay attention to this. Bloomberg sign is a clinical sign in which there is pain upon removal of pressure rather than application of pressure to the abdomen. It is indicative of peritonitis. So one way to remember is by calling this rebound tenderness or the Bloomberg sign. Okay. Of course, high fever, tachycardia, dehydration from high fever. These are all common sense signs and symptoms that are going to appear when you have an infection. Of course, if you have fever, it's going to be tachycardia, dehydration, and it's going to compromise your respiratory status. Inflammation and infection markedly reduce intestinal mobility. Auscultate for bowel sounds, which usually disappear with progression of the inflammation. As we spoke last time, be careful with bowel obstructions. It's kind of tricky concept, but we need to understand when there is an early symptom or presence of bowel obstructions, with your diaphragm, you're gonna hear high-pitched bowel sounds. But when the obstruction or the inflammation causing this obstruction is present for a very long period of time, then what's gonna happen is that you're gonna have absent bowel sounds. Be careful with that, okay? Don't let the vowel sounds change or um, make you feel that something is not right. It's the theory versus the physical assessment, but you need to know early obstruction, high-pitched vowel sounds. Obstruction with a long period of time is absent vowel sounds, okay? The cardinal signs of peritonitis are abdominal pain, tenderness, and distension. Yes. In the patient with localized peritonitis, the abdomen is tender on palpation in a well-defined area with rebound tenderness in this area. With generalized peritonitis, tenderness is widespread. Um, Laboratory assessment, of course, if it's an infection, our white blood cells are going to be elevated to more than 20,000 with a high neutrophil count, leukocytosis, um, uh, blood culture studies may be done to determine whether septicemia has occurred and to identify the causative agent. Fluid and electrolyte balance and renal status included blood, urine, nitrogen, creatinine, hemoglobin, hematocrit, oxygen saturation, and arterial blood gases might be obtained to assess respiratory function and acid-base balance. Arterial blood gases. It measures the acid base balance, the pH, and the levels of oxygen and carbon dioxide in the blood. Okay, so that's a concept you need to understand. In terms of imaging assessment, abdominal X-ray can assess for free air or fluid in the abdominal cavity, indicating perforation. The X-ray may also show dilation, edema, and inflammation of the small intestine, a small and large intestine, an abdominal ultrasound or computerized tomography CT scan may also be performed. Analysis. What are the hypotheses that we need to prioritize? Acute pain due to abdominal inflammation or infection, potential for fluid volume shift due to fluid moving into interstitial or peritoneal space. Planning, treating the cause of the infection and managing the infection process, managing pain. What interventions are we going to do? Interventions for peritonitis are usually non-surgical. Is usually treating the symptom, the pain, but surgery may be required to remove abscesses or other infectious material. Nor surgical management, assess for vital signs, septic shock, such as unresolved or progressive hypotension, decreased pulse pressure, tachycardia, fever, skin changes, and or tachypnea. So sepsis is always fever, hypotension, decreased pulse pressure, right, and tachycardia. Practice proper hand washing and maintain strict asepsis when caring for wounds, drains, and dressing. This is common sense as well. If the patient has or requires a urinary catheter, maintain a strict sterile technique. And do never forget, never forget to clean this urinary catheter periodically. Is very important and is very common UTI infections in the hospital care, okay, and it's preventable. Provide oxygen as prescribed. Let's go to the surgical management. If the patient is critically ill and surgery could be life-threatening, it may be delayed. Surgery focuses on controlling the contamination, removing foreign material from the peritoneal cavity, and draining collected fluid. An exploratory laparotomy, an open surgical approach requiring a large abdominal incision, or laparoscopy is used to remove or repair an inflamed or perforated organ. So what is our safety? Nursing safety priority. Monitor the patient's level of consciousness, vital signs, respiratory status. Okay. Why patient's level of consciousness? Because if we are having an infection in the abdominal cavity due to the big amount of, circulatory arteries, the network of the arteries, this infection can easily shift from the peritoneal area to the bloodstream, and this can cause mental issues, right? Declining mental issues in mental state. Vital signs, respiratory status, respiratory rate, and breath sounds, and intake and output of at least hourly immediately after abdominal surgery. Maintain the patient in a semi-fowler position to promote drainage of peritoneal contents into the lower region of the abdominal cavity. The position also helps increase lung expansion. So this is common sense. We are not gonna put the patient in a Trendelenburg position, right? Restoring fluid volume balance. Hypertonic IV fluids and broad-spectrum antibiotics immediately after establishing the diagnosis of peritonitis. Remind assistive personnel to take a daily weight using the same scale every morning and record intake and output carefully. A nasogastric tube is inserted to decompress the stomach and the intestine if a laparotomy is anticipated. So we are going to make a review on the hypertonic solutions. We need to be very knowledgeable about this because remember, nurses, we are the ones who can stop an error. If the primary doctor, or if we are working in a community hospital and there is new residents, if we note that the prescription has an error, we nurses are the one who can stop this. So hypertonic solutions are high solute concentrations and low water concentrations. Usually it's 10% of dextrose in water. It is called D10W, right? You have the 3% saline, the 5% saline, 5% dextrose in normal saline, 5% dextrose in 0.45 saline. Isotonic solutions include normal saline, right? Lactated ringer solution, 5% dextrose in water, D5W, and ringer solutions. Now let's talk about the hypotonic solutions: 0.45 sodium chloride, 0.33 sodium chloride, 2.5, etc. Okay, multi-system complications can occur with peritonitis: loss of fluids and electrolytes from the extracellular space to the peritoneal cavity. NG tube suctioning and NPO status require that the patient receives IV fluid replacement. Assess whether the patient retains fluid, and fluid retention could cause abdominal distension or pain. Home care management. Patients who have a localized abscess, a localized infection in which there's a collection of pus, drain, and who report to antibiotics and IV fluids without multi-system complications are discharged in several days. Others may require mechanical ventilation or hemodialysis with longer hospital stays, especially if the patient went through sepsis, right? And because of in the invasion of the bacteria in the circulatory system, we could have respiratory problems, right? Self-management education provide the patient and family with written and oral instruction to report. Unusual or foul smelling drainage. That's something that we need to monitor, especially when we have tubing, post-surgery, swelling, redness, or warmth or bleeding from the incision site at temperature higher than 101 Fahrenheit, abdominal pain, signs of wound dehiscence or ileus, Um, a dehiscence wound can appear fully open, the tissue underneath is visible, or it can be partial, where just the top portion of the skin has torn open. Okay. Any type of opening in a wound post-surgery, you need to report it because it's going to be a great opportunity for bacteria and for infection to occur. A home care nurse may be needed to assess, irrigate, or pack the wound and change the dressing as needed until the patient and family feel comfortable with the procedure. And it may sound silly to mention this, but not every family member is willing to care for a patient that is in a post surgery state. Especially, they don't want to change the dressings, the wound dressings. So you may need somebody to come visit, teach, educate, train the family members until they feel comfortable. Teach patient to refrain from any lifting for at least 6 weeks after an open surgical procedure, and this is again common sense. Patients who have laparoscopic surgery can resume activities within a week or two and may not have any major restrictions. So laparoscopic, these patients are going to go home soon, probably in a day or two, maybe depending on the type of surgery. They could go home the same day if the doctor sees that they are in good shape and they can recover home. But in terms of activities that require heavy lifting, or probably gonna take 1 to 2 weeks. um, Evaluations, we want the patient to verbalize relief or control of pain and infection and experience fluid and electrolyte balance. So we are always going to monitor our blood work, our sodium, our potassium, magnesium, calcium, all these electrolytes that are involved, right? Um, in this type of recovery, especially because if the patient went through peritonitis, they got fever, they got dehydration, these electrolytes are going to be um, out of the loop, out of control, right? We can have low sodium, high sodium, potassium, you know. So we always want to monitor the electrolytes. And with this, we just finished our peritonitis topic.